Well, good afternoon and good evening. On behalf of the CIC, myself and Dr. Myers would like to welcome you to the challenging cases in allergy, immunology, and respiratory disease. And we are chatting tonight on behalf of the consortium of independent immunology clinics, of which both Dr. Myers and I are part of. This program tonight is provided by Integrity CE, and this educational program is supported by our colleagues and sponsors at Pharming Healthcare, so we'd like to thank them. Tonight's case is going to be the activated PI3K delta syndrome, or APDS as we call it, which is an interesting inborn error of immunity, which is a great case to illustrate a lot of the new considerations, diagnostic tools, and treatments that we practicing allergists, immunologists may see, as well as our colleagues in a lot of different specialties. So my name is Jason Rosh, and again, thanks for tuning in tonight. I'm a physician at the Midwest Immunology Clinic, where I've practiced for the last 18 years in the suburbs of Minneapolis, Minnesota. And I'd also like to introduce, who you'll see on the screen soon, if not right now, is Dr. Myers. And Gordon Myers is an allergist immunologist as well, a colleague and a friend that goes back several years and practices in Cincinnati, Ohio. We'd like to draw our attention to our affiliations that we have with some pharmaceutical companies. And the main one I'm going to point out tonight that's relevant to what we're talking about is that I'm on advisory boards, a speaker, and a steering committee for Pharming itself. So tonight, what we're hoping to talk about, and what Dr. Myers and I would hope to convince you at the end, is how to think about new disorders as a broadening of what we treat in allergy and immunology. Much of what we see and what we label based on our specialty is what we call allergy or immunology. And a lot of times with immunology, we really think about immune deficiency. And what deficiency applies, that parts of our immune ecosystem aren't working. And it's what we will see in much of the disorders we as allergists, immunologists see. It's a dysregulation of immunity that may cause certain factors in our immune ecosystem to not work as well as they should, and some to be overly active. And so tonight we want to be able, after we complete the activity, is to better recognize the signs, symptoms, and clinical manifestation of the activated PI3K delta syndrome. And for ease of use from here on out, we'll use the acronym APDS. But we also want to understand the diagnostic methods used to confirm this diagnosis, when to entertain the idea, and how to get there to see if that's actually what our true diagnosis is. And then consider all the management options, including targeted treatment of the molecular defect in APDS, which is quite unique and novel, and one of the things as clinicians we hope for with each diagnosis. So in general, APDS can be considered a rare inborn error of immunity. So several years ago, there was a movement to transition from a label of primary immune deficiency, perhaps something that's genetic or we're born with, to this inborn error of immunity. And why that is because that encompasses far more than just a deficiency in the immune system. As I alluded to earlier, it encompasses any dysregulation, whether something is overly active or underactive in our immune dysregulation, how that could create a disease. It's estimated that worldwide there's approximately 1,500 patients with APDS. And to date, using some genetic testing, where it's a moving target, but where we are currently is about 250 known patients identified with this rare disorder. And you may think, wow, that's an ultra rare disorder. How am I likely to find one? This is likely an estimate. We think that there's a number of patients who are underdiagnosed. That's the first thing to consider. And then our opportunity to identify these patients, which can potentially have a directed therapy that actually targets a molecular mechanism, is enriched in our patient population, and we might find them. Also, as time goes on, as technology goes on, as knowledge goes on, we are likely to be able to identify from a molecular standpoint more disorders that have specific mechanisms that we can identify and treat specifically. With APDS, the clinical manifestations vary widely. We'll see that in some of the data. And at the end or near the end, Dr. Myers will provide a case presentation which highlights this. Genetic testing or a gene panel to establish the definitive diagnosis is available, which is really exciting. Despite this, diagnosis and treatment are often delayed simply because we tend to lump a lot of patients with APDS into other diagnoses because this is a relatively new phenomenon. And that's why attending a lecture like this is really important. Standard care for some diagnoses or early diagnosis of APDS have really kind of managed symptoms, but in an exciting turn, our first targeted therapy was approved in 2023, which we'll talk about in the future. And from a housekeeping standpoint, if questions come up within the Zoom platform that you're using, there's an area to enter your questions. So you can certainly log them there, but we'll also have time for question and answer at the end. So this is a very busy slide. This is we can all go back to our molecular biology and biochemistry. And the goal is not to explain this, but the goal is conceptual. And what you see on the left represents some B cell signaling or on the membrane of a B cell, and on the right, the signaling mechanisms of the T cell. And the details are not important as number one, illustrating the complex signaling that both B cells and T cells use to not only mature and develop and differentiate, but to also do your job. And if you were to look closely at the heart of this, right in the center, there's two purple rectangles pushed together, and there's this labeled PI3K delta. This is a signaling molecule that is quite ubiquitous in a variety of cell types. But for the sake of our discussion, the key considerations here is this version in B cell and T cells. And this signaling molecule is absolutely critical in the development function of B cells and T cells. And what we'll find with APDS as we go along is mutations in this signaling molecule, in the actual protein itself, can cause quite a disarray in this B and T cell development. And we find this immune dysregulation that it can manifest in a lot of different ways. So what this diagram shows you is that on the left is a oversimplified diagram of inside a T cell or B cell. And you can see a number of ovals and a circle there that really kind of describe the pathway for which this PI3K delta really helps to regulate. And when well balanced, as you can see from the center graph, there's this kind of blue squiggly line. It shows that the PI3K delta activity is highly variable based upon the needs of the organism and the cell. And what you're seeing on the right is to illustrate that you get these balanced immune cell subsets, whether it's balanced in number or in function. However, when you have a mutation, a pathogenic mutation of the PI3K delta, what you get is overactivity or constituent activity. There's no brakes. There's no accelerator. It's just all accelerator. And what you see in the graph kind of towards the middle with the red line is that there's very little variation in the PI3K delta activity. It's activated most times. And what that does, it drives your cell types, your B cells, T cells, and other cell types from more of a balanced population to an excess of immature or what we call senescent or sort of kind of going toward more the end of dying. They're on the outs. And then what that leads to on the right of that balance is a deficit of functional cells. And therein lies the problems and the manifestations that we'll see. As we mentioned before, the manifestations of APDS are highly variable and quite interesting. And as you see on the left hand, I won't read through these, but some of the key hallmarks is you can get lymph node enlargement, and lymph nodes don't just have to be where we see in the neck. It can be in our chest cavity. It can be in our abdominal cavity. It can be actually throughout our intestines. What you can also see is what we see more of a hallmark of primary immune deficiency, which is persistent, severe, recurrent infections, predominantly with the herpes virus family, which includes Epstein-Barr virus, or EBV, and cytomegalovirus, or CMV. We can see cytopenia, so decreases in platelets, white blood cells, or red blood cells, which are often autoimmune. We can see autoinflammatory disorders, such as like inflamed joints, GI, intestinal inflammation, etc. If we continue counterclockwise around the circle, we can see enteropathy. Enteropathy is not highly defined, but can be anything from a colonoscopy or an upper endoscopy, a biopsy showing a significant inflammation on microscopic level. Or it simply can be just asymptomatically we're having diarrhea, nausea, vomiting, food intolerance, and weight loss. Enlarged spleen, enlarged liver are also part of this, a part of APDS. And you can also see some very common bread and butter things like we see in our allergy clinic, like recurrent sinopulmonary infections, bronchitis, pneumonia, ear infection, etc. And one of the interesting features, as you see at the very top, is you can get developmental delay or failure to thrive. And if you could see this picture here is very interesting in that sometimes when you see things perhaps like cytopenias or persistent Epstein-Barr virus, you might think there's something hematologic going on, that this is something a little bit out there, something a little rare. But you can also be fooled by patients who just seem to have recurrent bronchitis and sinusitis. These patients too can have APDS. And to be very clear, patients with APDS do not have to have all these. They may have one or two. They develop over time. There might be something that's evident when they're 13 years old that wasn't available, or it wasn't evident when they're 7-year-old. So this is a diagnosis where constant reevaluation and rethinking of a patient over time is really important. So if you look in general, I really want to emphasize this point that these are generalizations. We as humans love everything to be very discrete and in boxes and be very algorithmic. And for all of us who've been in practice a long time, we see that's not the case. But in general, if you think about what would a patient who is a year under, an infant, have if they had APDS? Typically have their recurrent sinopulmonary infections. This is difficult because if you've ever taken care of children, whether you're family medicine, pediatrics, a pediatric specialty, almost all kids have some type of sinopulmonary infection. So it doesn't mean that every child who has a cold or bronchitis or a wheezer needs to be considered for something like an immune deficiency. It just shows you that this can start early, and we should neither jump to conclusions of a really rare diagnosis, but nor should we dismiss it because it's just a few colds that they had because they're in daycare. Typically by age of 3, we see this benign lymphoproliferation. What does this mean? You can have enlarged lymph nodes. You can start, if for some reason you happen to get imaging at this stage, you can see a little bit of an enlarged spleen. You may have unexplained lymph nodes in the axillary inguinal area. But one of the things too that we sometimes get fooled out is, let's not forget that tonsils are also lymph nodes. And so in a child with persistently enlarged lymph nodes and recurrent infection, you have to start thinking, even if it's in the back of your mind, is this something where we should think about immune deficiency, or based on this lecture, more inborn errors of immunity? Usually by 5 years old, if we're going to see an enteropathy, again, this could be diarrhea, this could be food intolerance, this could be vomiting, this could be failure to thrive. Usually we can start to see that around age 5. Again, as you see in the parentheses under, it can range anywhere from the first 18 years of life. Autoimmunity is a tough one because this is a term I struggle with because it's a very dramatic term that means very little when you pin it, right? It depends on how you talk about this. So autoimmunity, one of the common things we see is, maybe they have ITP, which is an immune destruction of platelets. Maybe they have an autoimmune hemolytic anemia. Again, these are very dramatic things. But these can be things as inflammatory arthritis. You could argue this could even be celiac disease. Don't forget, autoimmunity might include type 1 diabetes. So these are all things where we should always come back to. If we see these things in the back of our mind, we should always keep inborn errors of immunity on our differential diagnosis. By later on, as we get into adolescence, sometimes bronchiectasis sometimes arises. We will only typically catch this if we happen to get a CT of the chest, which if we do that, where we are obviously by that time, we're worried that there's something going on. But anytime you have a child with bronchiectasis, yes, we learn in pediatrics and pediatric pulmonary, we should think of cystic fibrosis. We always need to think of immune dysregulation, immune deficiency if we see a child or an adult with that matter with bronchiectasis. And often, but not always, I shouldn't even say often, we can see malignancy in around 18 years of age or so, or even before. This is typically something like lymphoma, right? But there have been cases that can be even something such as a myeloma or something like that. So these are always things that anytime you see any of this thing on this chart, yes, the differential diagnosis is large, and each specialty you go to that teaches you will think about a different one. But arguably, on each differential diagnosis, for any time we see something like this, an inborn error of immunity or immune dysregulation or immune deficiency should be one of our considerations. So let's talk about why APDS is important if it's so rare. As I mentioned before, again, this might be more likely, or diseases like it in that same realm might be more prevalent than we know. It's just because we're just learning about it. Again, sometimes symptoms can be very non-specific, like pain and fatigue and recurrent infections. Again, any of us who takes care of children and adolescents will see that this is quite a common symptom. For those of us who take care of adults, right, as well, we can see that these symptoms seem to predominate some of our clinics as well. Again, it doesn't mean that these are specific for inborn errors of immunity, but it helps you kind of think with the other pieces of their story, do we need to think about this? This can have an impact on quality of life, right? Such as sleep difficulties, impaired physical function, and even eating difficulties, which can cause failure to thrive. And then we get over to consequences like daily activity decreases, whether it's social activities, community activities, employment, emotional well-being, relationships. So all of these sort of subtle, sometimes subtle, lurking chronic symptoms can really impact quality of life. That's why diagnosis, or actually asking question about inborn errors of immunity, particularly APDS, is really important. Let's talk a little bit about the diagnosis of APDS. So as we mentioned before, the symptoms will likely vary and overlap with other primary immune deficiencies that might hinder it. And what do I mean by that? Primary immune deficiencies is a very broad category. And some of the data that you might read say so far to date, there's at least 500 genes that have been associated with some of the clinical features and other laboratory characteristics that we lump into primary immune deficiencies. And as this slide shows, of the 240 patients so far that were looked at the systematic review, most of these, even though this molecular defect was present, because we know it's a genetic immune defect at age 1, usually it's 12 and over by the time they actually get a molecular diagnosis. And sometimes the delay in diagnosis can be up to 7 years, which means most of these patients are between their primary care clinic and other specialty clinics quite frequently. So when should we suspect something like this, right? So in addition to what I've already talked about is family history. Sometimes it's easy to neglect family history. So it's really important to ask about things like recurrent or severe infections in a parent or perhaps a grandparent when they were younger currently. Asking about something like lymphoma, ITP, hemolytic anemia, or other autoimmune diseases in parents, siblings, or even grandparents is really important. Other times, sometimes if there's early onset symptoms that just don't seem right as a clinician, where you say, yeah, I've seen a lot of children, a lot of adolescents, but this one just seems, or something about it just seems a little bit more off than usual. Trust that intuition and at least entertain the idea of APDS. Recurrent respiratory infections usually occur in 70 to 80% of patients with APDS. So it's quite frequently there, but to be very clear and to everyone's point, I'm sure you're thinking about it, it's not specific for APDS. There's a lot of things that contribute. Even asthma can contribute to recurrent respiratory infection, but it's at least something we have to think about. We talked about this bronchiectasis, right? Having specific changes that you see on CT that are classic for bronchiectasis should make us automatically think about a number of things, but APDS and immune deficiency is one of them. Immune deficiency itself, that has a wide diagnosis, but if you see low white blood cells, high lymphocyte counts, which are another white blood cells. If you happen to get antibody levels, which we'll talk about, any increases or decreases, all of this, there could be clues that you're on the right track. Lymphoproliferation, sorry, I stumbled over that, can be part of that as well too. And remember, enlarged tonsils, again, it's not specific, but let's not forget that tonsils are also immune tissue. But an enlarged spleen, any persistent enlarged lymph nodes in the inguinal area, the axillary area, any of these things might give us a hint that there might be something more to the story. Certainly autoimmunity, which we talked about, and other ones I want to highlight are GI symptoms. That child that has failure to thrive that we cannot figure out, or even a young adult for that matter. Um, Delayed growth could be another one, just not reaching height, and neurodevelopmental issues. This is one that's really sneaky, but we're seeing it in patients with APDS. Whenever you have a child with seizure disorder or an adolescent, and you have there's some neurodevelopmental delay, and it's a child that might be sick all the time. Really hope I hope all of you remember this conversation we're having and to think about APDS. So we talked about some of this before. What are some of the first clinical manifestations in retrospect that when you diagnose someone with APDS that you can probably go back and find? You can see that the big blue half there is respiratory tract infection. But you can see kind of going from the bottom, kind of going clockwise, enlarged organs like spleen or lymph node, other infections that might not be respiratory tract. Maybe they have a bacteremia or a meningitis, failure to thrive, and so on. So you can see how this chart goes. And you can see we're coming back to the same themes, is that there's some features there that are not usual in the average patient that should kind of push us in this direction of thinking. So what's our workflow? How should we kind of formulate in our mind, what's the best way to approach this patient, right? So the first thing, is always going to come as the predominant feature, susceptibility of infection, right? Where then you think about, is there autoimmune features or lymphoproliferation or this failure to thrive? And you do the CVID, which is, again, we haven't talked about yet, but we will, where you have 2 or more antibody levels like IgA and IgM or IgG that are below reference range. And we work there and we start working those things. The autoimmunity might just be simply inflammatory markers, looking for antibody levels and vaccine titers, which we'll talk about. And ultimately, what this converges on is the box in the lower right-hand corner, which is a genetic test that can be obtained through a gene panel that can identify a pathogenic variant in this gene that will establish the diagnosis. So you might ask yourself, well, it sounds like, Jason, that there's a lot of similarities between, say, like a common immune deficiency, like common variable immune deficiency or CVID, which we mostly focus on the antibodies, and APDS. So how do we differentiate and why do we even care? Why does it even matter? Well, one of the things, if you have a patient with CVID, whether you make that diagnosis yourself or whether they transfer your care from another clinician, or you're in a specialty or primary care and you see this on their chart, here's some of the things that'll kind of help you think a little bit different, right? And you can see on the right with CVID, we tend to encounter this and make the established diagnosis later in life because sometimes CVID, we don't know the exact pathophysiology of that. And sometimes, and Dr. Myers can tell you the same thing too, sometimes we see this as early in the teenage years. Sometimes we make a diagnosis for the first time in the 5th, 6th, or 7th decade of life. And from an infection standpoint, CVID is going to be more sinopulmonary, bronchitis, sinusitis, pneumonia, that type of thing. APDS, we're going to see, yes, we'll see that, but we're going to see something like Epstein-Barr virus or CMV or any of the herpes viruses more often, whether it's cold sores or 2 or more cases of true so-called mono, that we actually diagnose when we do a PCR for Epstein-Barr virus. From a lymph strategy, we're going to see more dramatic things like an enlarged spleen, an enlarged liver, and APDS than we are in CVID. We'll see enteropathy. Yes, you can see that in CVID, GI symptoms, but we're more likely to see more severe forms of that in APDS. Some of the immune features, and this is where it gets a little bit tricky. Classic diagnosis of CVID is all your antibodies are low, at least IgG, IgM, or IgA. Not necessarily all of them, but certainly CVID is a low IgG and either low IgM or low IgA. But one of the clues to APDS, I really like to point this out, is that often, but not always, IgG is low, but the IgM can be elevated. So at any time that if you're working up a patient and you get antibodies, IgG and IgA and IgM, and you see that IgM that's a little bit elevated, right? That's not low, you should kind of look crossways at it because that should be a clue that there's something here. It might not turn out to be anything, but don't pass over an elevated antibody level, right? Um, and if we look at what gets more advanced, and I understand that not everybody may look at this, but your B cell profile and your T cell profile, you're going to see in CVID what we call more memory B cells, which we won't dive too much into. But for APTS, we'll see more naive and transitional B cells. And in the T cell compartment, when we break them down into CD4, CD8, this type of stuff, we're going to see more features where the CD8 cells tend to be more elevated than the CD4 tend to be decreased. A fair critique that you could say is that, boy, this sounds like some pretty advanced testing that may not be available to me. This is true. However, you do not necessarily need this data to get to where you might consider genetic testing, and we'll see some examples of that. So any of these features are more to it. This is all about trying to get us to all think about this disorder. We can worry about the details later, ask a colleague, phone a friend, something like that. This is really about how to think differently a little bit about some of the things we might encounter. Now, what about the treatment of this disorder? So remember, as we talked about earlier, the identification of APDS really only was about a little over 10 years ago now. Most of those patients who were ultimately diagnosed with this very specific molecular disorder came from a pool of patients that we probably labeled as other diagnoses like CVID or IgG hypogam or subclass deficiency or whatnot. It's really important to understand that all of us in the allergy immunology field who diagnose and treat patients with primary immune deficiency, we feel like within some of the big bins, the classic, very sort of vague diagnoses, within that are probably multiple, if not more, very molecular specific diagnoses that we haven't learned to tease out. But in the past, many of those patients who were later diagnosed as APDS with this overactive signaling molecule that pushes things to a more sort of burnout state, if you will, or more overactive state in some cases, were really treated based on their symptoms of infection, cytopenia, that type of stuff. So you can see at the top graph is that usually antibiotic, antifungal, and antiviral prophylaxis have been some of the hallmark, or usually most of the patients who ultimately were diagnosed with APDS. This is what we're on because we had nothing else. These are patients who had, chronic Epstein-Barr virus or recurrent CMV, viremia, that we had nothing better to treat them with than prophylactic antivirals or antibiotics or antifungals. Immunoglobulin replacement therapy, whether it's IV immunoglobulin or subcutaneous immunoglobulin, has been a hallmark of treating because most patients in some degree or the other have an antibody deficiency that we didn't fully understand, but most patients are on this treatment. Routine monitoring of Epstein-Barr virus and CMV is something that some patients have used. Personally, in the patients that I have not used this routinely, but more guided on their symptoms and their history. A little bit more advanced for patients who are severe. And remember, we talked about that there's a very significant heterogeneity, not only in symptoms in patients with APDS, but severity as well. If you look at all patients, all approximately 250 that have identified, you have some that were identified simply because they were in a family that had a member. They've been found to have a defect and have very minor laboratory or clinical findings. And the others who are quite severe and quite sick, where something like a bone marrow transplant is the only opportunity we have to try to sort of cure some of this molecular defect in their T cells and B cells. And remember, we talk about this is not a pure immune deficiency. This is immune dysregulation. There are some components of T cell, B cell activity, or some of the subsets in which it's causing a more inflammatory process. And that's why sometimes, maybe paradoxically, we think about using some immunosuppressive therapy like rituximab and sirolimus for some of the autoimmune manifestations or complications, whether it's cytopenias enlarged spleen, enlarged liver, that type of thing. And to be very clear, right, not every patient needs this dramatic therapy that we're seeing on the screen. The second thing, Dr. Myers, and I would really like to encourage you is just because you identify this doesn't mean necessarily you have to treat it. It's really identifying it first and then using us as a community of allergist immunologists who have experience in treating this to figure out what are the next steps. So, what are some of the risk and benefits of some of the things we talk about so far? Number one, antibiotic prophylaxis. You know, this is has had controversy for decades. The benefits, it can be inexpensive and may be very effective in some people. But some of the risks and shortcomings are things like resistant organisms. Not all antibiotics will help with specific bacteria. This does nothing for common respiratory viruses and that type of stuff. And these patients might often need immunoglobulin, whether sub-Q or IV in some way or form. That's what IRT is, immunoglobulin replacement therapy. If we think about IVIG or sub-Q IG, the benefits are that can dramatically and immediately increase your immunoglobulin levels and help reduce respiratory infection. But this does not necessarily help some of the cellular defects that we see in APDS. It does not prevent recurrent HSV infections. It does not stop lymphoproliferation. It does not balance things out. It simply adds IgG to the equation. The stem hematopoietic cell transplant has some evidence of being curative, but because of the nature of the molecular defect of the PI3K delta, bone marrow transplant doesn't correct all those in all tissue types. So we really see its importance in maybe helping with some decreasing life-threatening infections, lymphoma, but the process, the transplant itself can have major risks like graft versus host disease, infections, organ damage, that type of stuff. And again, no matter how cavalier we tend to talk about transplant, it's not available at all centers. And this has a big impact on families who might have to travel hours, if not longer, to get to a transplant center and this is a significant undertaking. Immunosuppression, and I don't like this term, I would like to prefer immune modulation, but using things such as sirolimus, azathioprine, a lot of different things. This can control lymphoid growth and autoimmunity, but it can also put the balance in other ways and actually impair our ability to kind of find and treat severe infections. And then you can have some other systemic side effects like metabolic or ulcers, marrow suppression, et cetera. So all these treatments, as we kind of alluded to earlier, really talk about more of the symptomatology of the disease. This talks a little bit about, despite SOC, which is standard of care therapy, this was one brief publication that really talked about all the different treatments, and you can see these on the left, that have been used for some of the patients that are currently in a registry. And despite treatment, over half met criteria for severe disease. And you can see all the different treatments have been used in the past. So what this gives you a little bit longevity, I kind of looked at or reviewed before, is that APDS was identified from a molecular standpoint in 2013. In 2016, 2017, there was preclinical trials on an inhibitor of this overactive PI3K delta. First clinical trial is a randomized control trial, and then an OLE means open label extension, meaning it was continued after the endpoints had been measured, has been available since 2023. And now in 2025, currently, there's approval of this inhibitor of the PI3K delta called leniolisib for APDS. And so what you can see here, this is reviewing a diagram that we saw before. At the center, or actually at the outer edge of the pink blob on the left, you can see the PI3K delta. And what this is meant to show is you're getting overall activity, which is pushes everything towards growth proliferation, survival differentiation, and excessive immature immune cells. And with what leniolisib does, it puts the brakes on this overactive molecule, very like laser-like, if you will. and restores the balance of naive B cells and regulated immune cell subsets simply by bringing this signaling molecule more in harmony with its typical job. So one of the things that was used in a clinical trial, you had to measure something. So the efficacy and safety of leniolisib for APDS, the efficacy part was really based on, again, we have to have measurable things. So yes, you can see that the patients improve, but one of the things objectively that we use is looking at lymph node size. You can see the graph at the left shows you that on leniolisib, if you look at the error bars, the lymph nodes after just 12 weeks of treatment show that there was a decrease in size, where on the right with a placebo, there was really no change in lymph node size. And one of the hallmarks of APDS is if we look at something called naive B cells. Again, naive B cells are those B cells that are newly minted and looking for their job to do. That's an oversimplification. A hallmark in APDS is that you have very few of these naive B cells. And that's bad because you need naive B cells to kind of learn to make new antibodies and that type of stuff. It's a little bit more complex than that, but that's the way to get your wrap your brain around it. And you can see, and for the leniolisib, if you look at the error bars, the naive B cells population has shifted dramatically upwards toward what a typical human were on placebo. Those naive B cells were quite low. And what this is meant by shrinkage of your lymph nodes and by an increase in the population of naive B cells, it's sort of both a macro and a micro or molecular examples of measurements that show that leniolisib really shifts the activity of the PI3K delta towards normality. And this is another graph that shows some of the lymph node changes, and SPD is a diameter. I won't go into this too much, but what the graph shows is that for the patients in each sort of pair of squares or circles, it shows before and day 85 of leniolisib, and you can see that the lymph node the diameter, an estimate, shrinks down significantly for all patients in leniolisib, but there's really no change in placebo. And what you can see here in a graph, and we'll see better in some photos coming up, is that the spleen volume or size of the spleen actually decreases in the patients during even 85 days is a relatively short time for a clinical trial. And even that short time, you can see significant change or decrease in the size of the spleen. And this is important, this is kind of a volumetric assessment of the spleen at screening and then after day 85 of leniolisib in 2 patients with splenomegaly. You can see in the 4 squares, the ones on the left, both the top and bottom, are 2 separate patients prior to leniolisib. And you can see even visually without measuring that there's been significant decrease in the size of that enlarged spleen with only a short duration on the treatment. Now, I should say that the treatment is intended to go on indefinitely, but in the window as defined by the trials, that was the short window to see if there could be measurable differences. What you can see here, same thing, you have 2 patients. The 2 squares on the left-hand side are made to show, and you can, it's a little bit difficult, but in the top square, there's a little right outline regarding a lymph node, and you can see on patient 2 below, that's actually a submandibular lymph node that's huge. And after 85 days on leniolisib, you can see significant marker reduction in the lymph node size. And again, why that is occurring is because all the lymph node or all the lymphocytes that collected there inappropriately because of dysregulation are now more regulated, right? And kind of clear the area and shrink the cells and things kind of go back to some normality. Effective this by age, this is a little bit busy, but what this is trying to show for the sake of time is that it, no matter what, if you divide out patients overall, those are 18 years or older, so-called adults, and those are in their adolescence, you're still getting some significant improvement no matter what the age group is in the adolescents versus adults with leniolisib, with all from the naive B cells, the lymph nodes, and the spleen size. Now, what about leniolisib? What about safety? So these are adverse events in grades for the different uh, percentage of patients that we're looking at. And if you look at what AE stands for as adverse events and TRAE is for treatment related, those adverse events that were very highly suspected to be due to actually the drug itself. And what an SAE is a serious adverse event, which means this is clinically significant that physicians and who are monitoring a clinical trial have to look at. And you can see of all the adverse events, very few were treatment related, very few were severe. And if you look on the right-hand side, the grades of it, most of the ones were grade 1, which are relatively minor overall. So what this is trying to convince us is that leniolisib was well tolerated and safe. And if we look again after the clinical trial, 85 days was the initial set that leniolisib was sort of viewed. Many of those patients went on to continue an open label extension of leniolisib. And right now there's data on patients going out 5 years now. And what the graph on the right shows is that you can see the lymph node size at the screen at 12 weeks of treatment, which is the 85 days, and the open label extension, which is more indefinite. You can see that the lymph nodes have decreased in size and stayed that way. You can see on the blue graph what these are patients who were on placebo, and 12 weeks there wasn't much change. But again, what the graph is demonstrating, once they were transitioned to the open label extension, that placebo group 2 had marked reduction in their lymph nodes. And what the image on the left is showing, and I'll be careful because it's hard to see, I understand, with some of the coloring, is what it's showing from screening to 12 weeks in open label extension on these very specific patients. You're seeing fairly rapid and sustained decrease in the size of the lymph nodes, which is again a clue that the immune dysregulation that was seen before has been largely curtailed and not quite normal, but markedly improved over time. And this is the same thing. This is the same thing looking at spleen volumes, that the open label extension, which some patients have been in 5 years, you have rapid and sustained improvement of splenomegaly and the immune dysfunction. This is an interesting graph that shows actually that the infections over time, right, from being on 1 year, 2 years, 3 years, 4 years, 5 years, has increased significantly or decreased significantly since studying leniolisib. And you could ask yourself, well, how does leniolisib have an impact on infection? Well, remember we talked about that part of the infection comes by dysfunction of the T cells and B cells. T cells, which have the ability to they have a lot of effects, but can be effective in monitoring and neutralizing viral infections and that type of stuff. B cells secrete cytokines, which coordinate immune function, make antibodies, and what have you. They can't do their job from a cellular immunity or a humoral immune deficiency or a humoral immunity when they're dysregulated. With leniolisib, you bring the PI3K delta back into more physiologic function rather than pedal to the metal all the time. You're going to get functional T cells back. You're going to get B cells that start making antibodies. And what we see from this is that you're going to get less autoimmunity because you're getting less dysregulated T cells that kind of stir up an inflammatory process. And so what you are doing is, again, you're getting at the heart of the problem, which is an overexpressed signaling molecule, which bring things in order. And again, what this shows is long-term, as far as adverse events, again, just because it's an adverse event doesn't mean you stop the drug. This can be any minor thing from gastritis to a cold or something like that can be an adverse event. But 90% of these were grade 1, which is a really minor adverse event, right? And there were no grade 4 or 5 adverse events, which required stopping the medication. And of all of these, none of them were thought to be related to the effects of leniolisib. If there was anything, it was probably more likely to the underlying the disease or some of the other treatments that the patients were receiving. So how does this impact patients, right? And here's some quotes, from a patient who talked about it with APDS, which said there's a point where I had to be in a wheelchair and on oxygen because my lungs weren't able to work by themselves. This is their actual phrases that they use when they talked about the disease. Another one said I couldn't do anything because I'd always be around the toilet. That's probably because of the colitis, gastritis, right? Couldn't get into the car because I was too scared to go to the bathroom. And another one was to be very meaningful, not to have to worry about the lumps or the lumps turning into lymphoma and the pain. So this is a patient that was affected by a lot of the sort of the physical manifestations that you can have with APDS. And another one said, be more meaningful, I spend more time with friends without having to worry about getting sick. And it's really important to understand that so many patients who ultimately go on to have a diagnosis of APDS really, really alter their lives just to function. And even a patient who was on intravenous immunoglobulin, um, they even said it's brought my life to a breaking point because, well, who's going to cover this if I don't get a job? And what am I going to do when I go off to college? Where am I going to get my infusions? How am I going to see my nurse? So you can see even some of the treatments of our immune deficiencies, which I think are helpful to patients, can sometimes be a little bit burdensome. These are some things I won't go over in detail, but basically they're different. The things you see on the left are just different quality of life measurements that you can see and that are looked at during the clinical trial and some of the other things. And what really this goes to is to try to quantify some of the disease burden that patients have with APDS. And if you look here, what this graph shows is one of the measurements, something called SF36. We won't go into details too much, but it really shows the changes in the quality of life scores with the different therapies that the patients have, right? And what you're going to go to see is that from each of these, you're seeing a statistically significant, and in the patient's words, clinically meaningful improvement in quality of life due to the things that improve once they were on leniolisib. So in patients with APDS 4 to 11 years old, it's a recent investigation has looked at the different patient population, because remember, this starts because it's genetic, really since the day of life. You might not have manifestations, but the gene defect is there. And on day one of life, you don't know how this is going to play out. So there's a lot of questions about, what does disease look like? What about therapy? But two things are happening now that we know about APDS. We might have a higher index of suspicion. And rather than diagnosing patients when they're in adolescence, we might see more in children and infants, particularly in family members who have APDS. Anytime that family history comes to light, we're also going to think of other members and maybe screen them. The consideration may be near birth or in infancy. So this is just about a patient population and a trial design about trialing leniolisib in 4 to 11-year-olds. And so right now, leniolisib is approved in the United States, United Kingdom for patients 12 and older. It's currently recommended for 12 years and over, and IRT failure, which that means being on immune globulin, is not required for this. What we can see is that because of correction of the T and B cell functions, the data is not in this set, but there's data to show that sometimes once you correct that molecular defect, we can transition some of our patients who are on IVIG off therapy, which is remarkable because in previous immune deficiencies, we never thought we would be able to do that before. You can see across the world in Spain that there's organizations there who are really supporting its use as a first-line therapy for APDS. And our evidence is showing it's effective in adolescents, adults, particularly with lymphoproliferation. And even though it certainly can be combined with immunoglobulin replacement, we're doing a lot of toying with the idea of trying to find out who still needs IgG replacement after they start leniolisib. So we covered a lot there. But now I think one of the things that always helps is to kind of put everything we just learned into sort of a case presentation that Dr. Myers will talk about, which is a patient that's based on an actual patient and modifying a little bit for clarity. But this, I want what I we would Dr. Myers and I would like you to do is pretend that this is a patient you are seeing in your clinical practice, whether it's a new patient, a follow-up patient, someone referred to you, but I have a feeling that you will all relate to some of the features of this patient. So Dr. Myers, take it away.
Dr. Rausch, thank you, sir. That was fantastic. Okay, now the only other thing that I would like to mention is that we're going to do a couple slides and then there will be a polling question. So we encourage you to take part in the polling question. And what we'll do is we'll go through each question and each answer option, and we'll try and highlight the important facts that, or how Dr. Rausch and I think about these patients as they come. Next slide, please. So this is a 44-year-old woman that comes to see us from a recurrent infection standpoint. The patient was recently hospitalized, requiring IV antibiotics. After discharge, the patient was seen by pulmonology. The pulmonologist got a high-resolution CT of the chest, saw bronchiectasis, gathered this incredible history of recurrent sinopulmonary infections, screened her from a IgG perspective, saw that it was low, and then was referred to our immunology clinic for optimal management. As we see frequently in the immunology clinic, we have these patients that come in and say, I'm just always sick. It seems that when I finish one antibiotic, I start another. Sure, I've had pneumonia. The most recent one, of course, with the hospitalization was the most severe, again, leading to her referral to us. Per the patient, she had pneumonia at least twice a year. And this has been going on for a while now. This is one of those things that's managed by primary care, urgent care. So whether this was bacterial, genuine pneumonia or not is of a moot point, because we are now seeing that we have this anatomic change with respect to our bronchiectasis. On trying to gather more detail from an antibiotic usage perspective, the patient does endorse that she's had at least 6 times a year that she does receive seemingly shorter courses of antibiotics that do require a longer extension into before there is significant improvement. When she's thinking about her peers, she certainly is sicker than, or more frequently sick and longer when she is thinking about her colleagues. Thinking about her husband, she is significantly more sick, more frequently rather, than her husband. And the same goes for her sister, who really has an unremarkable history from an infection standpoint. Next slide. So from a medical history perspective, she does carry around a tag of seasonal allergy. She has not been allergy tested yet, but the primary care, urgent care all endorse that this is the reason for her recurrent ear infections, sinus infections. Again, we've got her sister who has no remarkable history of infections, and there's no sibling history, of siblings being lost to infections. To try and curb this allergic process, she is on an inhaled nasal steroid, the fluticasone, and she's doing that 1 to 2 sprays twice a day. She's also on loratadine once a day, and she really hasn't seen much improvement, but she is encouraged to continue this therapy. From a hospitalization perspective, again, she had the one hospitalization for pneumonia. She really denies a other significant history from that end, but has been seen multiple times in the emergency department, urgent care for, again, these diagnoses of pneumonia, otitis media, and sinusitis. No significant history from a surgical perspective is noted. She does note that her immunizations are up to date. She believes maybe not the pneumonia vaccine, but for the most part is up to date. Next slide, please. So this is our first polling question. So in this patient's history, again, 44-year-old woman with recurrent history of infections, which feature is most suggestive of APDS in this patient? Is it recurrent respiratory infections without family history of immune deficiency? Is it recurrent respiratory infections requiring frequent antibiotic and hospitalization? Or is it the use of intranasal steroids and antihistamines without improvement?
Did we get some responses here?
All right. Okay. So let's see. Dr. Rosh, I think you can go to the next slide without me losing the poll, or do you want to just stay here?
Well, let's see.
Well, I like that.
Let's see, Dr. Myers. Let's see what we can do here. There you
All
go.
right. It worked for me. Okay.
Yeah.
So again, which suggests APDS most? So when we're thinking about this, the first option that we see is the recurrent respiratory infections without family history of immune deficiency. Now, well, we have the benefit of having, in some of these cases in patients with APDS, the whole sort of autosomal dominant, the trend that we see within the family history. We don't have that here. Again, sibling, really unremarkable history, and then the parents, again, unremarkable history from that end. So certainly in our world, when we have that and we see that there is this patient who has recurrent history, again, we do think about it from an immune deficiency perspective. That is correct. Option B, recurrent respiratory infections requiring frequent antibiotics and hospitalizations. We harp a lot on the red flags of immune dysregulation, immune disorders. So this is absolutely one of them that would clue us in, or as I like to say, it puts the red flag up in my head from an immune perspective. Dr. Rosh, do you have any thoughts on these two?
No, and we can see 60% of folks chose the recurrent respiratory infection requiring frequent antibiotics and hospitalization. So certainly, the first two, which people check from, are certainly valid.
Correct. Okay, next slide.
Okay.
Denies smoker, denies any alcohol, drug use, environmental factors really wasn't specified. And again, family history is not important, as in there's nothing to report there. Next slide. Review of systems, again, negative and normal, except as noted in the history of present illness. Did highlight some sort of, joint disorders and things like that, but has been played off as osteoarthritis from the primary care. Vital signs look great at baseline. Next slide, please. On physical exam, in an effort to sort of save some time here, I'm really just going to highlight that the thing that was most prominent is that on palpation of her abdomen did have mild splenomegaly. Otherwise, nothing significant to report. Next slide, please. So we have this history of recurrent infections. We've got splenomegaly. We have an absence of family history. So the next polling question is, what type of testing would you order for this patient? Would we jump down the allergy skin testing path? Option A. Would we get a chest x-ray? Option B. Would we do some further immune studies with the quantitative immunoglobulins? Or would we consider at this point jumping into genetic testing?
I think Dr. Myers and I understand that none of these may be perfect and there could be combinations, but this is really, if you had to pick one, where would you go? And just to kind of generate some discussion.
Okay, excellent. So, option A was allergy skin testing. 0% of people picked that. Good choice. Chest x-ray is one that I agree I would not have picked, in the sense that we have that high resolution CT that demonstrated bronchiectasis. So a chest x-ray would be, again, minimal benefit from there. The quantitative immunoglobulins, 83% of people came back and said, yes, that's exactly what I would do. And I have to agree with that. When the test came over from the pulmonologist, the only immunoglobulin we had was IgG. So we're really trying to tease out the next steps here from an immune process. 17% of people are not incorrect. They would go right to genetic testing. We do have enough here that makes us go, huh. So I agree with the above. Dr. Rosh?
Yeah, I totally agree too, and understood that in the real world, these are not either or tests. A lot of them are yes and, right? So quantitative immunoglobulins, think about a gene panel for inborn error of immunity. Those are all fair game. So excellent work.
Next slide. Next slide. Okay. So we're hitting some of these lab results. So again, to try and get some time here, CBC, CMP were really unremarkable, though you can see some changes that occur in the CBC, but for this example, it was unremarkable. What we found is that in the IgG, again, the total was low, coming in at 444 with a range of 600 to 1500 being the normal range. IgG2 was found to be low on this subclass, coming in at 98 with a lower range of normal at 150. IgA was also low at 37 milligrams per deciliter. IgM, again, this is one of the big ones that we see here, is that the IgM was elevated with a normal range of 60 to 263. Hers came in at 312. Next slide, please. From a previous vaccination response, she was protected to tetanus and diphtheria. Strep pneumo showed that she was initially protected to 2 of 23 serotypes, and then post-pneumovax was found to only be protected to 5 of 23, which we would absolutely classify as a poor response to the pneumonia vaccine. On further study with respect to her lymphocyte subset, they did have a low total T cell. And as Dr. Roche talked about, you can see the CD4, CD8 changes. I didn't mention that there, but you absolutely can see that here. And then from a total B cell perspective, the CD was decreased. CD19 was decreased, which we argue is abnormal. Next slide, please. Now, we have a better picture. We have fast forward through time. We've given a vaccine. We rechecked some of our titers after seeing the lab results, which you consider genetic testing in this patient.
Let's see, we're going to get some. Oh, here they come. The integrity people, I don't know if you can see. I don't think. Dr. Myers, are you seeing the results? I'm not seeing the results.
So I'm going to make an assumption. Oh, there
we go.
Correct.
Hey.
Yes, that's fantastic. Okay, absolutely. At this point, we're looking at this patient and we're saying, okay, well, we've got certainly some things that qualify us from a CVID perspective. And in my own clinic, when we have that CVID, I'm quick to jump to genetic testing to try and get better insight as to who this patient is from a genotyping perspective. And then when we think about, again, that IgM, that clues us in our world to say, well, maybe we can sort of hedge our bets from a genetic testing perspective. Dr. Roche?
Nope, I think that says it well.
Okay, next slide. Okay, so this again is, I think this is the last polling question for us, team. This patient has been diagnosed with APDS, right? We have one of the two genetic makeups consistent with APDS. And now we're starting to think about what would be a appropriate intervention from a first-line therapy perspective. Is it immunoglobulin replacement therapy as A, immunoglobulin replacement therapy and rapamycin or sirolimus? Is it immunoglobulin replacement therapy and rapamycin and Dr. Roche nailed this one. I cannot seem to pronounce it.
Leniolisib, yeah.
Of course, leniolisib. Is it antibiotic prophylaxis or is it something like a transplant?
So if it isn't obvious by now, Dr. Myers and I are full of grace and mercy, and we're just interested in the conversation. He and I would both agree that these choices are a little, well, I don't want to say advanced. These are probably imperfect choices, right? But it's to generate some kind of discussion, right? You could even say none of the above was on there. So just this is, again, it's all anonymous, so feel free. Here it comes.
Okay. So when we're thinking about this, immunoglobulin replacement therapy certainly is on our treatment thought process, right? We have this patient who has these recurrent infections. We want to give back to them what they're missing. Now, when we start adding in things like rapamycin and leniolisib, I think I got it that right time, we really start to see the benefit therein. And Dr. Roche did a fabulous job with respect to those images, the studies that showed that from a lymph node perspective, from a spleen perspective, when we have these patients who have leniolisib available to them and they're on this therapy, we find that this is a safe drug that has been demonstrated to really help our patients improve their quality of life and decrease infection frequency, et cetera, et cetera. So Again, I don't think there's a right or wrong answer here. This is purely just for discussion at this time.
Yeah. And you really, it's your treatment. As we learn about this, really you tailor it to what the patient needs and what the resources are available. And there's a lot of considerations. But I see 60% pick the choice that does have leniolisib. And I think the theme we're trying to get at as clinicians, all of us on this time together, we love the idea of identifying exactly what is out of place, the molecular diagnosis, and is there a therapy that will target that only, like with laser-like precision and right the molecular wrong that's going on. And that's the theme behind the leniolisib. The other things, antibiotic prophylaxis, immunoglobulin replacement, those are all true. And yes, and we can talk about those maybe a little bit beyond the scope of this discussion, but I think you're getting the spirit of what we were talking about for sure. And I'll close this window and we'll get on to the next. Dr. Myers and I are keenly aware of where our time is, so we'll try to respect that and complete the rest so we can wind up with any questions.
Correct. And we do have a great one, by the way. So I will work through this quickly. Yes, the patient was initially diagnosed with CVID while we were waiting for genetic testing. And then we came back and found that the patient was diagnosed with APDS. So next slide, please. In this case, again, fictional patient here, but the patient was started on immune globulin replacement therapy, leniolisib and rapamycin. And we reviewed all of those. When we are doing this, it is absolutely a shared decision making, and the treatment for this really gets tailored to what the patient has going on simultaneously. But again, in our patient here, patient is doing clinically well, and we will review and see if we can't change up her therapy in the near future. Next slide, please. Now.
So I can, if you want, Dr. Myers, take this home. Key points just to kind of review. APDS is a rare inborn error of immunity with variable presentation. What we're trying to convince you here, that even though it's rare, just because it's rare doesn't mean we should dismiss it. These patients are out there in all of our practices. It's our job to kind of at least look. But clinical features, recurrent infections, like so many things, but when you hear bronchiectasis or lymphoproliferation, autoimmunity, increased lymphoma risk, think about APDS. Again, just don't be too sometimes this can be overwhelming. It doesn't mean necessarily you as the identifier has to treat it, but this is where identifying it, the patients will be so grateful, and then we can work as a community of clinicians to kind of manage them. Diagnosis, you have to suspect it, but it's a pretty easy testing of a gene panel that can look for known mutations. Conventional treatments, as we talked about, may reduce symptoms, but often fail to prevent the severe disease. But leniolisib, the targeted therapy, is super hopeful given the fact that it targets a therapy. You can have the righting of the wrongs, if you will, and bring things into balance. And we're very curious and optimistic and hopeful that going forward, this will be a class of therapies that we have finally actually treat the underlying cause. So now time, and again, we respect time. We understand if people have to go, but any questions and answers are certainly welcome.
So the first question that we have is there any clinical data on the use of leniolisib during pregnancy/lactation?
Excellent question. Two ways to think about that. It could be that the mother is affected by a leniolisib, or kind of the nursing standpoint, the child as well. And I'm going to go with the short answer of no to limited.
Correct.
So it's an excellent question. And this is, as you can imagine, in any new therapy, especially with regards to pregnancy and nursing, certainly there's interest in that. It's a delicate thing to kind of sort out, but I think we will find that this will be a reality that will come out, and we'll get some experience over time. But the take-home message at this point is no, we're still gathering data on a lot of patients. But that is you echo a very important question we all have.
Let's see.
Any other questions? Or any closing comments, Dr. Myers?
No, I don't see any new questions, and I don't see anything. Oh, we have a new question.
Excellent.
Here we go. Okay. Clinical presentation and symptomatology are notably similar to acute pediatric leukemias, ALL or AML. Thoughts? Not so much a question, but more of a statement.
Yeah. And my background is general pediatrics, followed by fellowship in allergy immunology and 18 years of practice in allergy immunology. So I'm highlighting my lack of knowledge in the diagnosis and treatment of leukemia and ANL, and perhaps that may be AML. But that you highlight something, the question highlights a very important thing of the crossover of some of the signs of whether it's lymphoproliferation, cytopenias. You have the high index of suspicion for both. I think, not to oversimplify it, but I think basically the history and something even such as like a hematology slide can help start to differentiate between, is this ALL versus this is a more of immune deficiency thing. But this is something all of us who deal with inborn errors of immunity want to partner more so with our hematology colleagues because of the overlap. And we wonder if there are some patients with APDS because of lymphoma or lymphoproliferation diagnosis are actually in the hematology oncology clinics as well, the same way these same patients are in allergy immunology clinic. So I applaud that, the call out of the overlap, but hopefully at least kind of what fork to pursue could help you based on some of the other things we see in their clinical presentation or some other basic lab tests. So excellent question. Others?
We have another comment.
Okay.
Thank you so much. Great job. But other than that, I don't see any other questions.
So I think with that, we can conclude this session. I thank everybody for their attendance. I know as we kind of getting into the fall season, it's the evening. We really appreciate this. Dr. Myers and I will, kind of certainly welcome any questions after the program. And we'll be repeating this program, in a few weeks. So stay tuned if you would like to jump back on or have different questions or tell other colleagues that might be interested. But again, Dr. Myers and I would like to, as part of the consortium of independent immunology clinics, thanks Integrity CE for arranging this, and our fantastic sponsors at Pharming, who have really been supportive in the world of rare disease and inborn errors of immunity. So with that, we thank you and have a great evening and a healthy fall.
That's right. Thank you.